So welcome. Thank you so much, and welcome to our members. Sorry for that unexpected, intrusion of some stranger into our system. And I welcome Dr. Alita Maybach, Chief Equity Officer, and Dr. Jay Bhatt, a Health Innovator, and our moderators, Dr. Sunita Kanumuri, our delegate to AMA, and Dr. Pooja Kinkapwala, alternate delegate to AMA, and Vineet Mishra and Dr. Sujan Gogu. Welcome to all of you. Today's panel discussion is up to learn about health equity and how to strengthen ourselves, empower and equip ourselves with the knowledge and tools to dismantle the structural and social health inequities. So I can't wait to start this session, and over to you, Sunita. Go ahead and start the session. Thank you.
Good evening, everyone, and welcome. I welcome both our speakers and our moderators and all our audience and our physicians from API. As Anupama said, this is a very important session, and both our speakers, Dr. Alita Maybach and Dr. Jay Bhatt, have spoken on this topic a lot throughout the years. We will have four panelists who will be asking the questions, and we have our two speakers together. We have Pooja Kinkapwala, who is our MSRF past president and alternate delegate to AMA. We have Dr. Vineet Mishra, alternate delegate to AMA, adjunct associate professor of dermatology in University of California, San Diego. We have Sujan Gogu, who is a CAQ sports medicine and pain medicine, and he's also founding Circle of Doctors in Politics. With that, after our speakers, we have a panel of questions. The audience can put their questions in the chat, and I'm sure our speakers will be happy to address them. I would like to introduce our speaker, Alita Maybach. With that, she is very well known. She's actually written a few books. Especially, she was known for co-founding We Are Doc McStuffins. And also she has been quoted in New York Times, The Pandemic's Missing Data to Bring More Awareness to Structural Inequities in the United States. She's recently served as the Chief Health Equity Officer and Senior Vice President for American Medical Association, where she focuses on embedding health equity across all the work of the AMA and leading the Center for Health Equity. She joined the AMA in April of 2019 as their inaugural Chief Health Equity Officer. Dr. Maybach previously served as founding director for Center for Health Equity at New York City Department of Health and Mental Hygiene in 2014, and the Office of Minority Health in Suffolk County Department of Health Services in 2006. She's a nationally recognized speaker, writer, and advisor on issues related to health equity, the future of medicine, public health impact. With that, I call on Dr. Maybach.
Hi, good evening, everyone. Really great to be here. And I look forward to the Q&A as well. Good to be on with my friend, Dr. Jay Bhatt, as well. So I'm going to pull up my deck here. Hopefully you can see it, get this right. There we go. All right. Anybody? Oh, perfect. Now you should see something now, hopefully. Okay. I can no longer see you all for whatever reason, but can somebody just say, yes, you can see my slides?
Yes, we can.
Okay, awesome. All right, so I'm just gonna just spend a little time talking about the work that we have been pulling together at the American Medical Association. Equity work is not new at all. And, I would say that healthcare is probably a little, I think, behind, truthfully, in the game and in the efforts or in the movement, I should say, of doing this really quite explicitly, and especially along the lines of racial justice and anti-racism work. I come from the public health space. And I would say public health is definitely a little bit more forward-leaning in this, but I also don't say that they're optimal either. But it is a moment. The doors are open in many ways. Of course, there's much resistance as well. to doing this and leading in this direction. However, I think we've never been in a period of time at all in our history where we have been able to really galvanize a tremendous amount of energy in naming, racism as a fundamental and core cause of why these inequities exist within this country. And then secondly, the opportunity to be able to do something about it. And so first, I just give the land acknowledgement of acknowledging all that we are all living off in this country, the stolen lands of the stolen ancestral lands of Indigenous people. And we acknowledge the extraction of labor and life for Africans who were forced to this country more than 400 years ago. And so we continue to celebrate their strength and resilience. And I'm always clear that the work that I'm doing, I am standing on the shoulders of many ancestors, much sacrifice, so that we can continue to walk and walk in the direction of freedom, liberation, as well as joy. And so just some grounding terms, I think this is really important for me because lots of conversation around this focuses a lot on diversity and inclusion, which we know are absolutely important and critical. Folks need to have, diversity and spaces need to kind of recognize, appreciate, accept in different identities. It supports innovation, it supports and optimizes innovation. It optimizes the sense of how well people feel like they belong. And our ability to include these different identities also very critical. But I say that, those are kind of processes to get to what is really foundational. That's equity and justice as well. Equity really being about, the idea of redistributing power and resources to the places of greatest need. It's different than equality. And then justice is really about how do we move that structural context and those structural barriers that really get in the way of people having equitable opportunities and being able to be kind of valued and treated equally. So I really, words are very important in my lens. Many of you may have already seen this, a very simple way of the distinctions between equity and equality, and a very simple definition about health equity. It's having all four of these. It's not just one of these, but the conditions, the resources, your opportunities, and the power. A lot of times in these conversations, power gets left out. And that's really the core part of equity and justice is again, who's holding power, who has the power to make decisions, who is getting left out of decision making, and how are we shifting power and resources so that everyone has this opportunity for optimal health. Frames that I come with, I'm a public health person, as I mentioned, and I think it's an important frame, and it's an important frame that's left out of healthcare historically, lots because of the Flexner report of 1910 that was actually commissioned by the American Medical Association, but really caused our education to be very focused on the basic and clinical science, taking out the social context of health. And I think that was absolutely intentional for those who are in power, predominantly white men, really elite white men wanting to hold on to a system and a way of being and a value. And I think as the AMA, we have to completely acknowledge that history and contribution, but we need to acknowledge how that has had an impact on the narrative around health in this country and around what creates health. And I think it is one of the opportunities that we do have is to push this narrative beyond just clinical care and what happens in the doctor's offices and the walls of the hospitals, but to really understand and name, that health really is created 80% of the time outside of those settings. And that will impact more greatly, and especially if doctors are really having this voice to this, it will have a greater impact on policy and structures that set up those conditions in which people live in. And it will change the minds and the mindsets and how education is put forward, not only for us as healthcare providers, but for the entire country. So I'm very big on, what creates health and looking at the living conditions beyond just the language of social determinants of health, because oftentimes that's used wrong. But also talking about what are the structural drivers, where's institutional power driving those structures and how is it driving those structures? And then what are the root causes in those systems of power and oppression that are actually the lenses for how these these structures and conditions are really set up, and they're all listed kind of there on the left, and they don't operate in isolation. They're tremendous intersections. And specifically about racism, I got this slide in March. We all know, the digital transformation has been tremendous during this time. But before COVID, telehealth and all the digital work was like moving pretty slowly at a snail's pace. And then COVID comes around, and all of a sudden we're able to figure out how to do all of this. And I would say the same happened with the context of racism. And it wasn't just the exposure of inequities by COVID, but really the public murder of George Floyd that really propelled this country into a place again in a time of being able to talk about racism and name racism. For corporations, an unprecedented amount of money has been given across this country for racial justice. I think very critical, I'm not going to go through this slide in depth because I don't have too much time, but just kind of framing, I think I'm very big on words and big on definitions and committing those things to our memories, the same like we would do with anything else that we're learning in medicine. And I think this context of equity work, we have to do the same thing. We may not have learned it in med school, we may not have learned it in residency, but there's an opportunity to learn it now as we evolve as physicians. But understanding on the bottom right side of the system of racism, and this really, I have this committed pretty much to memory, because it's actually pretty simple after a while, but the idea of it structuring opportunity and assigning value based on race. And this is really interchangeable for any ism. You could put gender, you could put sexual orientation, you could put ableism or disability. There's a whole bunch of things that you could put into that context. And it's really a simple way to understand what these systems do of oppression. Structural racism being the ways of which, all these areas within our society, social, economic, political systems come together and reinforce, oftentimes really the negative aspects of what's existing and creates multiple levels of oppression around education, housing, employment, and the criminal justice system. And then lastly, in terms of a context, again, this is all just kind of context to how I come to the space that I think is really just important and critical at this time, is then understanding, the global context of this all, still focused here on this country, but the impacts of colonization and the impacts and the outcomes of setting up our systems of supremacy as well as capitalism, and these downstream effects that have caused trauma in many communities within this country, not just indigenous communities, not just Black communities in terms of African descent, but many communities and peoples and identities in this country. This was just released by Rupa, who I highly value. It is an amazing book. Like, I highly recommend you all checking it out. It's absolutely phenomenal. She and Raj literally just published, and it was just released and flamed. AMA released anti-racism policies last year. We did a pledge after the public murder of George Floyd, and then they adopted formal policies on racism as a public health threat, ridding racial essentialism, so really recognizing race as a social, not a biological construct, and supporting the elimination of race as a proxy for ancestry. And that's not to be confused to say we're eliminating race and collecting data on race and ethnicity, just for it not to be used as a proxy, and that we need to better understand the system of racism and its impacts on health, and not just looking at race alone. And so the big question for everybody is, like, how do we move beyond our declarative statements and move into action? And we know in the healthcare space, myself, Fernando De Mayo, who's on my team, Nancy Krieger, who's out at Harvard, and Ria Boyd, who's a pediatrician in California, very connected to the AAP, American Academy of Pediatrics, wrote a piece. We wrote several pieces, but looked at some of the data when the whole, actually it happened when the whole JAMA incident happened. And this had been on my mind actually for a while before JAMA incident happened, and just wondering, what were the numbers actually as it related to racism? How often was the word mentioned, but how often were there kind of empirical studies? And really the reality is not many at all. And so if there are huge gaps in what our medical journals are publishing, and we're getting really are the foundation of our guidance and guidelines that we create throughout health come from our peer reviewed journals, and they are not publishing on, and that racism is just one form of ism. If they're not publishing on any of these, you can imagine, we should all see that there's a huge gap in what we are creating and what we're leading action on, that there's just more we need to do to understand what's actually really happening in our communities. And so I think our roles are naming and calling out white supremacy. I'm very explicit about that now. I think it's racism was hard enough for people to say, but I think white supremacy sometimes becomes harder. But that is the overall kind of lens and umbrella, and patriarchy, I would add to that, of where all the other isms come from. White supremacy and patriarchy are the fuel for that in this country. And we have to be honest about that and acknowledge that. And when I say that, and I say that to just kind of break down the definition of that, so that, and I think it's more palatable for people, and it's really saying that there's this false notion of a hierarchy of human value based on skin color, with white being on top. That's what it is, simply by definition. And it plays out in many ways. And it doesn't just play out here in this country, it plays out in many countries across the world that we all are very well aware of. And then making injustice visible, not just through descriptive data, but again, looking at those systems of operation. And then how do we, as physician leaders, some of us in like high positions of power and decision making, but how do we do something differently beyond our own self-interest and our own experiences to really get people to really care? David Satcher, former Surgeon General, talks a lot about that now, that we need people who care. It seems simple, but we all know that there are gaps in that. So we released our equity plan a few months ago. It has 5 strategic approaches. I'll just go through them quickly. It is a longer plan, very intentionally, because we knew that the healthcare community was in very different places in terms of language, understanding concepts and terms around health equity. So really wanted to take the time to provide a primer to hopefully get folks to start building a shared understanding and analysis of equity and what it is. Our theories of change are really rooted in, righting injustices of our past, challenging our malignant and dominant narratives that are throughout health, centering our voices and ideas of those most marginalized, adopting an anti-racist and intersectional lens. So I say we lead with race and racism, but that's not to the exclusion of other forms of oppression, such as ableism, sexism, homophobia, all these other intersections. It's not to say that we are not addressing any of them, but what we're very clear about is that race is the hardest thing oftentimes, and racism for people to talk about in this country. We don't have a shared analysis. It's been out of our education. And so in order to keep it at the forefront of our work, we lead with race and racism. We need to embrace public health frameworks, again, an act upstream, and then an inside-outside strategy, I think, for organizational change work is very critical. And that's the first strategy, is really about embedding into the AMA. We have the management team of 1,100. We have membership of 270,000. So if the 270,000, I said that right, 100,000, if they're passing policy, we're the ones who are executing on that policy. So that means the 1,100 staff need to have a strong sense of what all of these things mean. How potentially are we exacerbating inequities in the decisions that we're making, whether it's our budgeting decisions or hiring decisions, programmatic decisions, policy, advocacy decisions. So we're doing a lot of work with staff to really shift and change mental models, culture, and ways of being at the AMA. And we're using models that exist. This is from the Government Alliance for Racial Equity. It's what I used before in my role at the New York City Department of Health. These things are online. I won't go too much in depth. And then this is from the Racial Equity Tool. And again, it can be applied really to anything. But these are like the critical questions that when anything is created, any new system is created in any of our settings, are we understanding like who's benefiting from or who will be burdened by our proposal that we're putting forward, and what are our strategies for mitigating unintended consequences? All these are really important questions to ask in order to really start to implement an equity lens to the work. And we're getting ready to come out with a communications and narrative guide as another tool that will come out in less than a month from now. So, it will kind of expand and build on the strategic plan. The pushing upstream to address all determinants of health, as I mentioned in the beginning, this to me is a huge gap in terms of medical knowledge and understanding. It's just not understanding public health in the full context of what creates health. And I think that's really problematic for physicians, from my point of view, who are really considered leaders within the health, care system of our systems of our country. And so we need to find other ways to increase their knowledge, our knowledge, help support what does it mean for them to understand what does it mean and how to dismantle structural racism, and then equip them with tools as well. So we did just launch 2 weeks ago the Health Equity Education Center on the AMA Ed Hub. There are lots of tools and resources there. We are having some kind of brand new created content with different partners from across the country that will be displayed. And then we're also using content that has been created, because there's no need to like reinvent the wheel if there's already information out there. But I highly recommend folks to go check it out. And we're always open to hear any advice. We just launched our Medical Justice and Advocacy Fellowship. They had their first weekend together last weekend. And this is an opportunity for physician leaders across the country to really start to learn and to have a deeper lens into kind of equity and justice, and learn more about what are the opportunities for organizing and doing advocacy at their local level, but also connected to the national level. This is in partnership with the Satcher Health Leadership Institute, David Satcher's organization at Morehouse. Daniel Dawes is now the executive director. So core to that is them understanding what are the political determinants of health. And then also our foundation just launched the LGBTQ Fellowship, another opportunity, again, for physicians to learn more and to have tools, skills, leadership skills, especially on engaging and advancing the health of LGBT communities. And then just to mention another part of kind of moving upstream in advocacy, which is, a big piece of what AMA does and organized medicine does overall, is that on the left-hand side of the upstream, the right-hand side of the typical kind of downstream opportunities with an equity lens that we have participated in. But I think it's important to know that AMA is now kind of really starting to look at other upstream opportunities to support advocating, to support in terms of advocacy, things related to housing, hate crimes, other funding opportunities for different communities across the country. So there's more and more that we're going to be doing. And then lastly, just in the time that I have, is our last approach is around like fostering pathways for truth, reconciliation, and healing for our own past. We're very clear, and most people know that AMA excluded Black physicians. In the strategic plan, actually lists out several of the harms. I think there's about 2 pages of harms that AMA has committed over the years. And there are probably more. That was really our kind of surface level of doing that, with working with our archives department. But we're going to be now going deeper into this work of really trying to quantify the effects of AMA's policies and process decisions that excluded, discriminated, and harmed, and work towards finding ways to repair and cultivate healing. We have issued an apology that many of you all know about in 2008, but even in that, Ron Davis, who was the president, said that was only a first modest step forward, and really we're pretty silent since 2008 as it related to racial justice and equity at the AMA. So, 2 years ago, the center was founded, and here we are today. And then another move that I think to me is pretty monumental, our CEO, Jim Madera, back in February, after reading a few articles that he came across that were actually published in 2008, realized this very strong role that Nathan Davis, who's the father of AMA, played in excluding explicitly women and Black physicians. And because of that, he had his bus removed from public view at the AMA headquarters and placed in the archives earlier this year. So those are the kind of, that's the kind of work, I guess, that people are doing, that we all have to do as leaders and leadership. And I think and it's not, I say this is not just the work of Black and Brown people. I think that's really critical and important to say. because oftentimes it lands on our shoulders to do. However, it's not only our work, this is everybody's work. And systems of white supremacy really are perpetuated the most by whites. And so it's really important that they're doing the work. But I think it's also important for us as communities of color to also look within our own communities and recognize the internalized racism that exists within our own communities, within our own families, that also drives these inequities in our country. I come from the Caribbean, and half of the family is from here. And so, but especially in the Caribbean, there are lots of deeply rooted beliefs that align with this notion and this myth around a hierarchy of human value based on skin color, based on lightness of this skin color. And we have to be honest about that and how it shows up for ourselves, for our families, and how that impacts the decisions that we make as physicians. And then lastly, this past fall or this past summer, the House of Delegations passed legislation to do truth and reconciliation healing work, specifically on the Flexner Report. Flexner Report, as I mentioned already, a kind of what it did to the kind of culture of medicine and how we were trained, but also it recommended for the closure of 6 of the med schools, or 5 of the 7 med schools at that time, all 3 women med schools. And there were lots of other impacts of the Flexner Report that we need to be honest about. And so I'll stop there and definitely open to taking any questions at this time.
Thank you, Dr. Maybach. Actually, we have Dr. Jay Bhatt speaking right after you, and then we are open to questions.
Oh, great.
And with that, I'll have Pooja come in to introduce Dr. Bhatt.
Thank you so much, Dr. Maybach. That was an amazing presentation. I'd like to introduce Dr. Jay Bhatt. He is a versatile healthcare executive with experience in public health, healthcare quality, strategy, innovation, business development, operations management, applied research and analytics, population health, and health equity.
Unmute Dr. Jay Bhatt.
Great. Well, good evening, everyone. It's just a pleasure and joy to be here with all of you. And thank you for your leadership and all that you do in having this conversation. So, Dr. Watimukwala, thank you, along with your team, for bringing us together tonight to talk about this really important issue. And to Alita, Dr. Alita Maybach, she's just such a gift for our profession and for this work of health equity that we do. And I just am grateful that she's leading the charge here with this work with many others, certainly at the AMA and beyond. And I'm just glad to be in this moment with her talking about these issues. So Alita, thanks for the incredible leadership you're providing and all that you're doing. So I'm not going to use slides, and so we can get to conversation soon, but I'll just talk about some of the ways that I think about this issue of health equity, and just really underscore the focus on systemic structures that Dr. Maybach talked about, and talk about it a bit also in this notion of that history really walks alongside us. So, if we think about our history as South Asians and Mahatma Gandhi and his philosophy, and the relationship that he had with Dr. Martin Luther King Jr. And Gandhi and his philosophy were of special interest to the progressive African-American community, referring really to the African-American freedom struggle. Gandhi had called the practice of segregation a negation of civilization. Many leaders in that movement here in the United States, Howard Thurman, Benjamin Mays, William Stewart Nelson, and Dr. Martin Luther King's colleagues also had visited India. And Gandhi's philosophy directly influenced Dr. Martin Luther King, who first employed strategies of nonviolent direct action in the Montgomery bus boycott. When we think about this issue of power that Alita spoke about, it's really important to think about that, understand where power is, what influences power has, and how it keeps the status quo to remain, or can challenge that status quo. And so when we think about power, we also think about resources. And so Rosa Parks and the numerous individuals that made this boycott successful really used their feet as their resource by not taking the bus to fight the issues at play there, segregation and others, which impacted the dollars that then went to the bus company. And so it's, when we think about these issues, really important to map out and think about where power is held, what are the resources, what are the interests at play of the different stakeholders. And so I just wanted to connect kind of this issue of really the significance of Gandhi's 1928 Salt March and his fast to end discrimination against the untouchables, but also all that played out since then. And now I bring it back to this work that we're doing to improve health and healthcare in America. And when we think about the Institute of Medicine's report about To Err is Human in 1999, one of the aims there of the 6 powerful aims that were outlined in that report to address medical errors was equity. And it's critically important that that equity work is broad, but it also rests on some of the structures and systems that Dr. Maybach talked about. So when we think about quality and the notion of health disparities, which has been used as a term quite often, and talking about terms is important because I think language matters and how people think about issues. So a health disparity is an unjust quality gap for a given condition or population. When we think about that, many of us and the OPPI community know and understand quality. And health equality is the lack of these quality gaps. But then when we talk about achieving health equity, it means reshaping health to when, where, and how it is needed to provide the same opportunities to everyone and remove the gaps. And we think about kind of the slide and the pictures that Dr. Maybach showed, we're thinking about the issues of how we might define equity. Everyone gets the support they need, which may be different, but that can produce equity. And then this issue of justice being really important, the systemic barrier being removed. Now, some of you may know that we are unfortunately bending the life expectancy curve the other way because of how there's a mismatch in our spending. For other countries, our peers that are developed countries, for each dollar they spend per capita on healthcare, they gain in life expectancy. And for each additional dollar we are spending, we're starting to lose in life expectancy. And that's a mismatch around medical and social costs and this relationship about what actually drives health. And so some of you may know Elizabeth Bradley, who talks about this issue, and more importantly, this issue now that we're really in the first generation whose children may not earn more than their parents. And that's particularly when we look at people of color, we also know that inequality isn't evenly shared. So in 2019, the poverty rate, 10.5%. And in 2020, we had the sharpest rise since the 1960s to 11.7%. More than 8 million Americans fell into poverty. And so we know that certainly COVID had something to do with that. But the other thing I would say is that America's health inequities in our country is a chronic condition. We've put Band-Aids, or not even let it be out there in the open, as we saw last year, and not actually thought significantly as a system upstream. And we know that there's a challenge with data and accessing data. There's a challenge with a we versus I culture in communities. There's a relationship between discrimination and health outcomes that can impact, as was alluded to by Dr. Maybach, around trauma. And so, microaggressions can also impact the health of individuals and communities. And so when I think about the issue of language also, and a lot of organizations, and particularly we took this on when I was at the American Hospital Association, several things. One, that social determinants or social factors or environmental factors, economic factors, we're getting kind of put in the same place as social needs or health equity, systemic or structural issues. And so if we just take the example of housing, and housing I use because housing is health, the life expectancy on average for those with unstable housing is 27 years less than those with stable housing. So when you look at the social need today, when I saw a patient who was experiencing symptoms of headache and allergies, the questions I asked were about what level did she live on? Basement. What was happening with mold in her environment? What was her carpet like? So that avoided a CT scan, avoided a specialist, avoided potentially suffering days off of work for a single mother who couldn't unfortunately do that. And we were able to treat her differently because that's what was causing her headache, the environment that she lived in. And so that's a social need. We work with the tenants and help her get to a different housing situation. Now, when we think about the issue of the environment, there's a lack of affordable housing in communities. That's a systemic issue, but take it one, and some may call it social determinant, but it rests on policies like redlining and zoning policies that may have created decades of housing that isn't affordable for communities. And so, just say that because it's important where we intervene, and understanding where you are and where you intervene can often lead to better outcomes rather than a circular that doesn't lead to the outcomes you want. And then the other issue I'll raise is the issue of trust. Communities and the path of health equity relies on trust. If we can't generate trust between organizations and communities, individuals and communities, ourselves and our patients and their clinicians that care for them, then that will make it only harder. We have to use lived experience as an opportunity to listen with empathy and learn and make changes both at a policy, systems, and environment level. So what I'll do is I'll just stop there and move on to the next segment here of this program, but just really appreciate the opportunity to be with you all today.
Thank you, Dr. Bart. Thank you, Dr. Maybach. Thank you, Dr. Bart. We will open now for questions. It's open to both of you. There's some from audience also. So with that, Vineet, I could call on you to start.
Yeah, sure. Thank you, both of the speakers, for their excellent presentations. I'm still a little bit confused about the concept of health equity and how we define it. And sometimes I find that if we can't describe the components that go into health equity, it may be difficult to have a benchmark by which we can measure success. Can you kind of just briefly go through again, your definition of health equity, and what are, let's say, the top 3 or 4 things that you believe helps to define health equity?
So I wish I could pull back on my slide. So I think in the simplest way, health equity is really saying, and Jay, Dr. Jay, I'm going to say Jay, you can call me Alita. It's just easier, please. We can do that. Is optimal health for all, right? So the idea that everybody has the resources, right? They have resources, whether it's insurance, money, whatever it is, cars, transportations, whatever, to get to health. They have the opportunities, so they have access to whether physicians or they have public health opportunities in order to achieve optimal health. They have conditions. So when I think of conditions, I think about what are the environments and the neighborhoods of which people are living in. Do they have supermarkets in their neighborhoods? Do they not have supermarkets and access to them? Are they far or are they close? As an example, hospitals, you could say that, but let's take it out the healthcare system. And then do they have the power? And power comes in many different forms. Power typically in this country, really a lot has to do with voice and decisions, but also money and financial power or political power, right? Voting contributes to that as well. And so we need to have those, all of us have to have the ability to have the power, the conditions, the opportunities, and the resources in order to achieve optimal health. And what we're very clear about, so that's getting to health equity. What we're clear about is that not everybody does have the same opportunities, the resources, the power, and the conditions. For many of the things that Jay mentioned, things that are just obvious, poverty. You know, I mean, we see it in the news every day, especially now. You know, violence in your neighborhood, that inhibits so many opportunities for people if they have that. Joblessness, unemployment, you're limiting opportunities and access, especially in this country, to healthcare if you're not employed. So if you don't have those things, you have less ability to have optimal health. You have all of those things, you have more ability to have optimal health. And in this country, wealth is very much connected to your ability to have all of those things, because you can choose where you live, you can choose where you go to school, you can choose where you go to the doctors, you usually have power because you have money. That's how I contextualize health equity. Jay, I don't know if you have something else you can add to in terms of a framing.
No, Letha, I think you said it well, and I think your slide that paints the picture of looking over that fence or trying to, and at the baseball field, I think outlines those issues. And that, I would think that we also think about health equity in a broad way, even though people of color are disproportionately affected, and there's a history that is alongside with it. We think about also the issues of place, disabilities, veterans, gender, right? So I worked with a hospital in rural Georgia who asked a simple question: what's the difference of our diabetes rates among men and women? Diabetes readmissions. And it was 22% for women and 12% for men. So the question is, why is there that difference? And so they worked over a course of 3 years to close that gap. So that's one way you can look at it. But the other is also to what Alita just talked about, is opportunity. I think we often look at the issue of equity sometimes from the gap lens, but it really is also about the opportunity lens. And so the opportunities you're able to give everyone. And that, we see our own community of South Asians impacted by this as well.
And the other point I would just say about equity too, to add on to that, is that you can look at it. So oftentimes, and to the point of the gap part of it, historically, at least within the last years, people talk about equity in the context of disease and outcome. And that's one way to look at it. But equity is also a process. It's a strategy, but it's a process. And it's a process by which we need to ensure that there is, so I mentioned earlier about these aspects of diversity, that people have equal pay. All of those things are process and outcome measures, but they're really ultimately important as it relates to health equity itself. And so, there are the large kind of outcomes. We look at life expectancy and we look at premature mortality, and those are all markers and metrics that we follow. And we've been following since formally in this country since 1986, when Margaret Heckler actually released one of the very first reports by the federal government to look at why these numbers were different across the country. And that was really the first thing from there. And ever since then, really, this country has been trying to figure out what to do to close these gaps related to health equity. And have we fully gotten there yet? Absolutely not, because clearly they're still existing and they're actually getting worse across this country, especially during this time of COVID.
Just a follow-up question to that one is, do you believe that the past few years we have taken a step back in achieving health equity? Or do you think that by having more dialogues, we're actually getting closer to that, closer ideal perfect union state?
Jay, do you want to start first this time? Go ahead.
I think we've made progress. And I think this is a window of opportunity, because the pandemic has impacted essentially everyone in some way or another, but it's also illuminated the inequities that systemic structures have laid bare. And it's really unearthing the events that have also surrounded, right? There were multiple pandemics, racism, misinformation, COVID-19, all of those, I think, helped us see our shortcomings and struck up conversations. And I would say, I think it was more monumental and catalyst as what happened with the unfortunate death of George Floyd. I think that sparked a lot of, I think, conversation and thought. But so did the impact of how frontline workers and service employees were impacted by the pandemic, including healthcare workers on the front line. And so I think there's more work to do. I think the thing that I get concerned about is, how do we make this sustainable? How do we make it long-term? And it's not just for the moment, right? We saw with Katrina and that unfortunate tragedy that there was a lot of work and catalyst that emerged during and after, but how much of it was actually sustained? And part of that was because, it affected a region of the country. And although that was in this country, not everyone saw themselves in it. And I think COVID-19 is really different in that regard.
Thank you, Dr. Butt. As a follow-up to the same thing, there's a question from the audience on addressing mental health equity. Like we are talking on health and equity, but there's a little bit less discussion on mental health equity. So what are your thoughts on that?
Yes, I mean, I will go to saying kind of what I said at the top in terms of the narrative around what health is. And I think we as physicians have to take a lot of responsibility for that and how our system has been set up and structured, and the segregation between the physical health and our mental health. And we all, for the most part, know, hopefully, we know, like they're clearly intersection. We are one body. So, it should not be segregated in that way, but I think we have to stand up and take the responsibility to name always, to the point I see the comment, and I absolutely agree with it, that mental health is, I don't want to say it's the inequity. What I want to say is that because of our segregation and how we think about health, it's not focused on. It doesn't have, the power is not behind the conversation as it relates to mental health. And we need to shift that. And I think we all can take that responsibility in shifting that and how we do it, even to the point in my presentation, maybe I need to say, what I just said more explicitly, as I talk about this, I'm very clear about it. And we do a lot around like trauma-informed approaches, which to me kind of incorporates the whole context of emotional, social, and mental health well-being. But in terms of how our system is structured to really address those things, we still have lots of gaps as well. And yes, payment for mental health is absolutely awful. But we are very powerful within this system of healthcare, and I know that from being in the AMA now than before. And I want to give a shout out to Bobby McConnell on the phone here somewhere he was somewhere. But Bobby's been just an awesome support since starting at AMA, and really a tremendous leader for the work of equity at the AMA. So just really want to acknowledge you. But we as physicians, we have, I think, an opportunity and a role to elevate more about these gaps as it relates to mental health.
Sure, thank you. What does it mean for organized medicine to be involved in equity work? Like, what can API as organized medicine also do?
Jay, were you going to add something else onto that?
Yeah, I would just on mental health, I was going to echo, Alita, what you said, but also say that, I think it's this fragmentation of physical and mental health that has, in some ways led a construct of thinking about it differently. I mean, I'll just give the example of carve-outs in insurance. If we're thinking about it in an integrated way, why do we organize and pay for mental health carve-outs in insurance programs? That's one example, and there are a number of others. And we know life expectancy is 25 years less than the rest of the population for those suffering from mental illness. They experience poor health outcomes. And the issues systemic and structural, and that of racism, impact mental health, right? So which then impacts physical health and outcomes. And so I think there's a lot of work that we have to do. Workforce diversity, workforce supply, integrated structures, and that has to be a core part of our health equity effort. Sorry, thanks, Sunita.
Thank you. So John?
Yeah, I wanted to ask, can you talk to us a little bit about kind of how you've navigated institutional barriers to being an advocate or activist promoting health equity? You know, a lot of times we've seen during this pandemic, physicians that are speaking up, they're facing retaliation. And so how do you navigate the institutions that are there?
Yes, thanks for that question. This has been my work for the last 15 years, so like I'm hired to be a disruptor. So sometimes I have to take a step back from that and recognize that not everyone, to your point, has that opportunity, right? And are not getting, definitely not getting paid or paid attention to for it. And a lot of times because of power and power structures, while folks may say, and especially during this time, like we're about health equity, we're about anti-racism work. However, we want you to kind of, let's just be silent. Let's just figure out how to kind of tiptoe in this. And I hear a lot of those stories across the country. And usually what I say is, thinking about it as in with any other movement that happens, take it outside the institution. The strongest way, and I think the fastest way that action actually happens is not by the individual, but finding who your community and your collective is going to be. It's just like your group here, right? It's just like organized medicine. That's what it is. And it's that group coming together. So finding those other kind of champions, leaders, supporters of who else wants to do equity work within your institution and coming together with them first. That's my strategy. And putting forward some ideas for action. And those ideas for action may simply be, we collectively are going to go to, our leader or some other person in power that maybe you have a little more trust in, that you can get some guidance on kind of how to proceed forward or how to engage with that top level leader if you don't feel comfortable going with that. But what I would say is not to do it alone and to find others within your organization to do it together. And that's where I think most of the more successful efforts have really happened at the institutional level.
So I would just add to Alita's wonderful comments that I think it's also being able to ask the question. Often, we are in circumstances where we maybe just go go about a set of activities or a set of work without stopping and say, could it be better? How are people impacted here? I think it goes to the slide, Alita, you put up earlier about the questions to ask. I think, another person who thinks about this in a really powerful way is Dr. Kamara Jones, and talks about, we are in a position where it's not a new normal, but moving toward a hard reset. And so on structures, who's at the table and what is on the agenda. Policies is the written how of decision making. Practices and norms are the unwritten how of decision making, and values are the why of decision making. And so I think all those things become really important, and also thinking about default settings and history in that context. Organizationally, I would say, we have to establish an institutional commitment to advance health equity. Create and clarify your commitment really by writing health equity goals into critical documents, such as mission statements or strategic plans, and then establish permanent structures to improve health equity practices. And, Alita just shared a textbook approach to that, but that there was a lot of learning along the way. It wasn't smooth sailing, I'm sure, but it was learning and stakeholder engagement and challenging the status quo. Creating informal systems to empower people in your organization to identify and contribute to these health equity efforts. And an organizational assessment. One of the things we did shortly before I left the American Hospital Association was start to say, let's assess our own points of view, biases, unconscious and implicit, and not only in the senior leadership, but across the organization and in our governance and beyond. And I think that that kind of work, it's you got to start internally to then be able to impact stakeholders externally. And then the other, where possible, align funding decisions with your commitment to health equity. Be deliberate in your actions, your language, your recruitment, your building, organizational capacity and skill sets, and then track and capture, right? We can't improve what you don't measure. Efforts in training, performance, bonuses, et cetera, and integrating health equity into services and resources, and then multi-sector collaborations and relationships based in trust with diverse communities. I think that, those are all important elements.
Mm-hmm. I agree.
Thank you both so much. I have a question specifically for Dr. Maybach. In your presentation, you shared all of the wonderful things that the AMA is now doing to address health equity. But my question is about, what were your first steps? How did the AMA structurally begin to make those changes to advocate for health equity and social determinants of health, as there's conversation hadn't been had in prior years? And what are some things that we as OPPE members and OPPE leaders can do to start that conversation and start those steps to promote health equity in our organization?
Yeah, Bobby can correct me if I mess up on this, please. But I would say the work started, definitely didn't just start. And I alluded to that a little bit around the time of the apology, and a little bit before that. There was, I think, and it's interesting to think about who was president at that time as well in this country. But there was, I think, somewhat of a ground softening and recognition and appreciation around equity, and at least disparities is what they called it at that time. And AMA, along with the National Medical Association that was started for Black physicians, and the National Hispanic Medical Association came together, and they started a commission to eliminate disparities. And from my understanding and reading it, there were something like 75 professional societies that were a part of this group. And so I just say that, while it's definitely more obvious, and I think lots of intention clearly around the equity work, there was a little bit of a footprint, that was there. And then the apology was there. And as I said, it became somewhat quiet over the years in between. And then around 2016, the commission was no longer, but the House of Delegates, really felt, and membership felt, that we needed to kind of shift as AMA and think really much more directly, what are we going to do as it relates to health equity? There was a task force that was created to provide some recommendations to the board on what to do and what should be the way forward. And so those recommendations, and key to that recommendations was one, developing a Center for Health Equity, and two, having somebody who was, a position that was going to oversee and lead that center. And so that resolution was passed in 2018, and then I was brought on board in 2019. And so really, it was the House of Delegates and the recommendation to the board that created that opportunity. And then I think that was tremendous, because that means now, that's a commitment, because it's structural. And it's one of the reasons why I did choose, to come over to the AMA, because it was structural. I felt if it wasn't that, I was less inclined to come, because to me that demonstrates true commitment. And then the question, are there going to be like real resources to doing this work, funding and money to actually do this work? And there was always that commitment. And I think, anybody will say, wherever your dollars go, that is what you truly value, at least in this country. And the roots of capitalism, we're very much aligned with those kind of values. So that is, how the work started, really at the AMA. And, I will say what was really great about that, because it was rooted in House of Delegates board and membership, there was so much kind of excitement when I first came on board, to the point where I didn't even really, I was like, how are we going to handle this amount of demand for so much? And I was like, oh boy, but, so it's a good thing, but it was also, we have to figure out how we kind of wrap our heads around all of this, so that we can move forward in a meaningful and helpful direction, or else we could be pulled in so many different directions. And I think, definitely now having the strategic plan out, kind of provides us that kind of air and room to settle a little bit, and now kind of figure out, what are the actions that we're doing moving forward. And I say that all, the plan is not finished, right? It's not something that's going to be just one and done. This will evolve and grow over time. We have to, as somebody measured, I mentioned earlier, there's a whole evaluation component. We have to measure progress and impact, and that's harder in the equity space because it is a newer field. It's been around, but it's still newer. And so there's not a lot yet out there in terms of measurement, but we'll figure it out.
Yeah, I just wanted to add to Alita's comments, which I think are spot on. My experience at the American Hospital Association when I was chief medical officer, but also had responsibility for our diversity, inclusion, and equity agenda, is that we had a subsidiary called the Institute for Diversity in Health Management. And what we did is have a series of conversations over several years to say, well, what's the end destination? The end destination isn't diversity. Diversity is important and critical to get to the end destination of health equity. And so, there were challenges just because of people's relationship with diversity, inclusion, and history, and but then got to the place of calling it the Institute for Diversity and Health Equity, and really actually structurally investing in it, investing in policies, process, metrics, resources, and then eventually actually saying, we're going to look within and also make it a part of the mainstream of the association, right? It didn't need to sit as a subsidiary, but that it could be integrated across the board. And so that was, work that was, to Alita's point, not one and done, but took conversation, learning, trial, learning, and then moving forward. And the other thing we did was we were charging $500, per member to participate in that, and actually just said, why don't we lift all boats? And why is that a barrier? And actually, it just became an added component of membership. And so, I think that there's important work and questions that go along the way, but having the metrics and coming back regularly saying, what are we learning and how does that impact where we're going, I think is critical.
Thank you, Dr. Bart. I would like to acknowledge Dr. Mukamala, Chair, Board of Trustees of AMA, and would like to hear a little bit on your perspective on the same issue.
Thanks, Anita. Thank you for allowing me to be a fly on the wall. I always enjoy these conversations, and to the question about how we got to this point and where were we before. I see this as an evolution of our own thought processes as physicians. And so the AMA represents the 1 million physicians in this country, not just the 200 some thousand that we represent as with their membership. And with a heterogeneous group like that, there's going to be varying willingness to acknowledge the nature of this bias and then do something about the nature of this bias. And so even though the pendulum is moving in the right direction, it took a while to gain this momentum. And as Alita pointed out, we have policy and letters documenting our acknowledgement of this issue of the nature of inequity and bias in provision of care to our patients more than a decade ago. And yet we are just now seeing the momentum that Alita noticed and then came to our organization to lead this work because we are finally acknowledging it and doing something about it. And so it's not something that turns on a dime. And even now within our organization, there are subsets of the people within the AMA policymaking body that aren't at the same place. And so I think education is key and awareness and taking a course on health equity. There's a lot of information out there just so that we are all on the same page, right? I mean, when my local high school down the street puts in their letter at the beginning of the year that critical race theory will not be taught to students in the school, we have a long way to go in just raising the collective understanding. And so, I'm proud of our organization for doing this work. I'm proud of API, which I'm a lifetime member of, for making this the topic, because there is a lot of raising the level of education among us that needs to be done if we are going to impact this problem.
Thank you. I know Dr. Maybach has to leave, so Dr. Anupama, do you want to conclude?
Yeah, thank you. Thank you so much, Dr. Maybank, Dr. J. Bart, and thank you, Dr. Bobby McCamala, giving us that little, So I was thinking this topic, and several other topics which are burning topics for us as physicians. And so I thought this is a very good opportunity for API to educate our members. So that's how I picked up this topic as my first topic, but I have physician burnout and other topics still next few months. So this subject, why it interested me, are we, recent episodes of, brutally killed by police and all these racial comments we go through in our daily lives, in our practices. So where are we on this? So that's what kind of triggered me. Why should we not do this topic to our members? And our medical students and residents, and do they have this in their curriculum yet? That was my question. I don't know the answer, but is it included in the curriculum? I think if not, then I think this should be something which should be the students should be aware of, because more and more we see this in our practices. I think more and more we need to know about this important subject. And I know racial inequity, it does impact the mental health, emotional, spiritual, and physical health of people of color. Dismantling systems of oppression is the work for all of us. So I want to conclude. Thank you, Dr. Maybank. Thank you, Dr. Bart, and thank you, Sunita, Pooja, and Sujan, and Vineet for excellent questions. And with this, I conclude this session, and thank you so much for listening very patiently. And it's a Wednesday evening. I know it's a working day, so thanks a lot. And sorry for that initial glitch we had when we started. Somebody corrupted our system. Yes, yeah. Thank you so much. Hope I meet you, Dr. Maybank, someday.
Yes, thank you. Thank
Thanks.
you, everyone.
Thank
Thank
you,
you.
everyone. And
Thank
thank you for having this conversation.
Thank you.
Bye.
Thank you.